Well, that 6 months took a long time, and we didn't get anything out of it.
Yeah, if you're watching this, you might notice that the rest of the video or the beginning of this video, depending on where this clip goes, does not match because we are in our new studio. But we had anxiously been awaiting the publication of the secondary, I suppose it was the match analysis
Yes.
with Miami heart cohort for the lean mass hyperresponder study. Basically trying to answer this question of in certain people with high LDL and elevated ApoB, does coronary artery disease begin, progress, cause problems?
In those that are allegedly metabolically healthy.
Allegedly.
Does high LDL progress plaque? And we're posting our discussion that we did about 6 months ago, and we listened to it again, and it sounds like all of it is still spot on, because in the preliminary release, which we consider a movie trailer, when the actual movie came out, there was nothing else exciting in the movie. So unfortunately, comparing the keto group and the Miami heart trial, they made the conclusion that there was no significant difference in the progression of plaque, but their analysis was not good enough to make that claim, and we explain why.
Yeah, and I don't think there's data is still pending on the progression of plaque, but the existence of plaque in this phenotype or the existence of plaque in the Miami heart cohort, they showed with their statistics that the LDL did not seem to be associated with the degree of plaque volume. So my candid criticism is that the imaging tests are only as valuable as the person interpreting them, and the scores used in a total stenosis score is just not practical and doesn't yield clinical useful data. Candidly, the Miami cohort did a much better job. They labeled the percent of patients that had greater than a 50% stenosis, greater than a 70% stenosis, high-risk features, and for whatever reason, this didn't happen in the lean mass hyperresponder or the keto trial.
Correct.
Very
disappointing.
Positive thing to say is that some people criticize them for excluding people with known coronary artery disease, but the Miami heart cohort did the same. So it is apples to apples in that regard.
Yes, and we know they get the CCTAs, which is excellent. And I assume they put them through a service like Cleerly, where you can calculate both flow and plaque, or HeartFlow, where you can also calculate both flow and plaque. But there was no atheroma volume posted in the trial result. There was no max stenosis posted in the trial result, and there was no CAD-RADS score posted in the trial result. And if those three metrics don't make sense and you're not sure why they're a better way to analyze plaque than what they did, then we explain that ad nauseum in the podcast ahead. Today, we found some very interesting, you could consider it emergent info about the lean mass hyperresponder study. This could affect the revascularization of your heart. And basically, we looked at the clinicaltrials.gov info. We found how they came up with their total plaque scores and total stenosis scores. And we talk about the strengths and limitations of that, mostly limitations, and how that could be done better.
And in an individual not in the lean mass hyperresponder study who was a lean mass hyperresponder, we talk about how an individual had a heart attack despite being a quote-unquote lean mass hyperresponder.
Welcome back to the Gillett Health podcast, where we give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett.
And I'm James O'Hara, nurse practitioner. Today we have an emergency revascularization podcast. And why are we calling this podcast Emergency Revascularization?
Yeah, whenever we have a piece of data or something so interesting that we have to share it that week, we call it an emergency podcast. So whenever the oral contraceptive O-pill went over the counter, we had that emergency contraception podcast. And now we're having our emergency revascularization podcast because there is new information that could affect the vascularization of your heart.
Yeah. And speaking of emergency revascularization, let's talk about a 51-year-old male, a lean mass hyperresponder. What happened to this guy?
Yeah, so this is a published case study, and this individual had a
history of revascularization, I believe in his proximal LAD. And after, going on a statin, kind of like standard of care therapy, he decided to go off of his statins, go on a ketogenic diet. His LDL skyrocketed to at least 300, which we'll talk about. And he unfortunately had an MI.
Yeah, interesting. Not to the area that was originally stented.
Correct. To areas which previously had no clinically significant plaque, even a couple years before on catheterization.
Yeah, and unfortunately, we don't have the exact timelines here. We know that he was 51 when he had his second coronary intervention. He was at least 49 when he had his first stent placed. We know that he was off atorvastatin therapy for at least 2 years. During that time, interestingly, it described him as trying to use a ketogenic diet to manage his cholesterol levels.
And CAD.
And coronary artery disease.
Ketogenic diet to manage cholesterol levels and CAD. And it did manage his cholesterol levels. It went up from discharge the second time, I believe his LDL was 13. And on admission, after he had the myocardial infarction, you expect LDL to be a bit lower acutely, and it was still over 300.
Yeah, so his baseline labs, LDL, not on any medication, was 131. Likely had an elevated LPA when he was, let's say, 45 or 49, whenever the first intervention was. And also, when they did this first cath, they saw moderate stenosis, but only distally, so only really far down the RCA, right coronary artery. 2 years after coming off the statin, they saw that he had severe stenosis, a 95%, and then a 99% distally. So that same area that was probably below 50% if they weren't intervening, progressed to 99%. And then a new area that maybe it even had 10% to start with, but it progressed to 95% in that same time period.
So if we were calculating his total stenosis score, now we don't know exactly what degree of stenosis he has or an atheroma volume, but just to kind of play devil's advocate here, greater than 80 or greater than 85%, whichever the cutoff was, that'd be a score of 3. So if he got a score of 3 for the distal right coronary, that'd be 3 plus 3, the right coronary, that'd be 3 more, so 6. And then the LAD, presumably if you have a stent somewhere, then that probably equates as a 3 as well. So at least a score of 9, which would not have put him in the highest category in the lean mass hyperresponder category and study.
Yeah. And again, this is kind of just a thought experiment because I'm not sure where exactly these things split off. We do have a nice diagram here of the coronary arteries, and this is your typical anatomy you would see.
Yep.
But yeah, if he had a 99% occlusion in 3 separate areas, assuming that they weren't extensive, that they were confined to one segment, then he could very well have a TPS, total plaque score, of 9. And the max score is 45. So think, 9 out of 45, not too bad.
Yeah. That being said, I guess you could make the case that every case study is a thought experiment because it is at the bottom of the pyramid of evidence-based medicine. So really when you talk about it, it is as a thought experiment and should not necessarily change clinical management for every patient that you have if you've read a case study on one patient that had an outcome. But it does help you to identify patterns in practice.
Yeah, and I bet this gentleman wishes that there was a study going on during his self-experiment where he could have gotten a CCTA and then a CCTA a year later, because he was at a stage where they could have tracked that progression of the plaque volume in the RCA.
From a total stenosis of, it was moderate, so probably would have gone from like a 5 or a 6 to a 9.
You would hope they would look at the plaque volume, so like millimeters cubed, or run it through a Cleerly. I assume that a radiologist can put these 2 CCTAs side by side and see if there's progression from one year to the other. But running it through, adjunctively, an AI Cleerly protocol and having a radiologist verify it, seems like more ways of looking at the data would be better.
Yeah. By the way, I think it mentioned that his BMI was 23. How do you know if he's a lean mass hyperresponder? That means you have a lot of lean body mass, right? Or a lean hyperresponder?
Yeah, I think this is interesting. They call it a lean mass hyperresponder. And I don't think that these individuals who have reported these like significant perturbations in their lipid profile are
Hmm.
tremendously massive. They may be very lean,
Hmm.
or at least much leaner than the general population. But I don't think you would have someone who's let's say, a professional strongman who has a ton of lean mass,
Yep,
but is not necessarily lean from a body fat percentage standpoint.
definitely.
I think from the phenotypic response of LDL going up from a ketogenic diet, they would be less likely to experience that compared to someone who is, let's say, 140 pounds, but they're 8% body fat.
Yeah, that's a good point. And I guess we could also say, in order to try to give some actionable items, rather than just taking a cutoff of a BMI of 26, and if your BMI is under 26, you're a lean mass hyperresponder. I mean, even despite being extremely tall, my BMI is over 26 despite being 14% body fat. So am I a lean hyperresponder? Apparently not, according to BMI. I would rather say cutoff of 16% body fat, maybe even 20% body fat for males on a DEXA. I've seen so many people get in bodies and their DEXA 7, 8, 10% higher within that same week or even that same day. That seems like a more reasonable cutoff.
Yeah, and in the enrollment criteria, they do you have your waist measurement handy? Because they cut off for a BMI between 25 and 30 was a waist measurement less than 40 inches for men.
Yeah, definitely less than that.
So you could pack on quite a bit of belly fat and still be qualifying as a lean mass hyperresponder.
Wow. Could get presumably a peri-umbilical measurement where you take the tape measure and you measure around the umbilicus, which is the belly button, and then all the way around the back. I could probably literally weigh 300 pounds. Yeah,
That's
quite
a lot
confident.
of mass.
Yeah, I could be a lean mass hyperresponder, not a lean mass. And I do think it makes sense to call this lean hyperresponder, not lean mass hyperresponder. But if we wanted to call it lean mass hyperresponder, or if it was really proposing that there was some sort of an anabolic muscle building benefit, like you get more tender swipe yeses if you're a lean mass hyperresponder, then, and that was a joke, by the way, then use a fat-free mass index of 21 or greater.
I heard you attract more, what's the term? Gold diggers. If you mention how high your LDL is.
That would be hilarious. You put it right next to your height on Tinder.
Height, LDL,
Yep.
for those looking to cash out.
Height, 6 foot plus, LDL greater than 190. We've probably bored people enough with that banter. So we briefly talked about plaque score, stenosis score, segment involvement score. We had that board last time where we were ripping it off and saying, this is crap, like that Argentinian president, but
who balanced the deficit as of now, correct? I think that now they have their first balanced budget.
Yeah, they're surplus, in fact. It's not political advice, but seems like a cool guy that I would enjoy hanging out with.
I like to have a personal balanced budget, not be operating a deficit. So, I mean, it just kind of aligns with my thoughts on how you should spend and not spend money.
Yeah, seems like a good idea. But I guess back to the whole point of this podcast, the new information that has come to light that has made this an emergent, and obviously it's not an emergent thing, but it's just something that we want to talk about right away, is the criteria for how they made the segment involvement score, the stenosis score, because we were postulating, we know this is kind of a crap. This is not an ideal measurement, for lack of a better term. Actually, we could have a better term. This is not a clinically
it's not
actionable.
It's not going to help the clinicians that are dealing with patients coming in with this study. Whenever this comes out in a year and the results are analyzed and people are, there's going to be headlines, LDL may not matter. Not that that's necessarily accurate, but if you are a news corporation, you want to get more clicks to get more ad revenue, and that's just the way it's going to go.
Yep.
So then the physicians or nurse practitioners or PAs that are on the front lines of this talking to patients are going to have something that is, clinically actionable. And I have never seen a CCTA report a total plaque score. Now, in the actual, if you go to clinicaltrials.gov and you type in and you find this study, you will see that they are looking at an endpoint of total soft plaque volume.
Yep.
So they're going to count for like, hey, if some plaque is calcifying, like we know that's not a malignant process. That's something that is generally thought to be more stable plaque, lower risk plaque.
Yep.
So they're measuring the change in total soft plaque volume. However, they did not, at least in the presentation by Dr. Budoff, I believe is how you say that, cardiologist, UCLA, he did not mention a plaque volume that was given, which is something that I would be more familiar with personally than a total plaque score.
Yeah, and again, the reason for our interest in this is not to have a certain position. Our friend Dom D'Agostino from University of South Florida, we are in the same boat as him. We want to figure out what the clinically actionable takeaway from this is. And actually, we're in the same boat as Dr. Budoff and Nick Norwitz and Dave Feldman and the other individuals involved in the lipid community, metabolic health community. We spoke in the same conference, the Metabolic Health Summit, and we also want to know, this is, actual scientific desire to figure out what did these CCTAs look like before and what did they look like after. And at the end of the day, that's what we want to answer. And we think that our proposed ways is a slightly better way to know that.
Yeah, I think it's an interesting study. I generally am happy that it's being done. And there's people that are critics saying, well, you're harming people, but there is an informed consent.
Yep.
I assume people are being counseled on like, hey, there are known risks or proposed risks of most people for having elevated LDL. And, a lot of people will have that intermediate risk score, right? They have that conversation. If you're in the traditional medical environment, it's like, hey, your risk of an MI in the next 10 years is 7 point something %. You should consider a statin. That's the typical protocol.
Yeah.
And a lot of people will say, no, I don't want to take a medication. So I don't see how this is directly causing harm to the individuals participating in the study. And we've had plenty of failed interventional studies that have caused harm.
Yeah.
So I don't think that's a valid reason to say we should pull the plug on the study. This should never be being done.
Yeah. I mean, let's just, for all intents and purposes, obviously people do ketogenic diets and other metabolic therapies for purposes other than to manage their cholesterol and CAD. That's why we're making fun of the paper that says the individual was on it for his cholesterol and CAD. Probably not. Probably body composition, aesthetics. Maybe he's on it for bipolar disorder. Maybe he's on it because he has a brain tumor. There's lots of other reasons to do it. And maybe he had like really severe epilepsy. And with the care of a neurologist, he decided to do a ketogenic diet. You can say the same thing. Let's say this study was on Seroquel instead. Somebody with bipolar disorder is on Seroquel, and they wanted to look at the progression of plaque and dyslipidemia secondary to that non-metabolic pharmaceutical therapy. And, there's huge amounts of people, thousands and thousands of people on Seroquel that want to know their cardiovascular disease risk secondary to it, whether it's higher or lower. They don't care. They just want to know. Same thing for people on ketogenic diets and metabolic therapies. They also want to know their cardiovascular disease risk, whether it's higher or lower, the same, and what they should do about it.
And they're getting this paid for, right? If I'm a ketogenic dieter and I've found some measure of success with this diet, these people have been on this diet for at least 2 years going into the study, then yeah. And someone's like, hey, do you want to get a free CCTA now and a free CCTA a year from now? Heck yeah. That's a pretty good value. And you get to be part of something that is answering your question. And we know that some of these people are not going to have progression.
Yep.
You know that from people who have diabetes and smoke and have high blood pressure. Some of them don't have significant plaques on CCTA. Some don't have any plaques on CCTA.
Yeah.
So some of them aren't going to. And then the question becomes, can you or how can you predict who is going to? And the question is this hyper response of LDL going up, ApoB going up, is it pathologic or not? At the end of the day, that's all we're trying to figure out. Is it a benign state where it's not causing harm? Is it a harmful state that people should be aware of?
Yeah. And it does seem like in the absence of other factors that simply raising your ApoB and letting that run sky high, the causation is essentially proven at that point, but you can argue that the metabolic benefits, probably in certain patients, may to some degree outweigh, whether it's partly outweigh or equally outweigh
the detriment of the dyslipidemia that comes from it.
Yeah, it's a really interesting space because at the end of the day, if you're taking care of someone on the individual level, so this is not a study that's going to have something actionable for the general population. This is something that is following people at the individual level. And if you're taking care of someone at the individual level and you don't see evidence of lipids contributing to pathologic features, which the coronaries are not the only place that can be affected. You can get tendinopathies, lipid infiltration into the connective tissue. You can get xanthomas. You can get some of these other evidence that, hey, looks like cholesterol is accumulating places it shouldn't. But the one that's going to affect your life, quality of life the most is accumulating in the coronaries.
Yeah.
So it's really looking at these, I think it's 80 people as individuals and seeing what happens to each of them over time.
Yeah. Of note, if I lived in a perfect world where every single study idea, however extravagant, could just instantly be completed, I'd love to see the same study where everybody is on ezetimibe.
So another arm.
Alternate universe, yeah.
Okay.
They split the time continuum with Doctor Who, and then they follow the exact same group on ezetimibe, or they just get 80 more people and try to stratify them as best as possible.
That's on a statin, and then another group that's just adding Oreos, right?
I guess you could say that too, because
there's an infinite number of parallel universes. There's no limits here.
I understand. I just pick ezetimibe because it's the least controversial lipid med that has good evidence with relatively few side effects. So if I was going to be on a ketogenic diet with I call myself a borderline lean mass hyperresponder. If I eat anywhere low carb, I've never done like a true ketogenic diet for a long period of time, but my LDL does pretty easily go around 190 and my ApoB does go up, 150, 160s. And I know it could go much higher. So I'm borderline in that category, but I'm just not going to do that. Not on ezetimibe.
Yeah, it makes sense. And you don't have a particularly compelling reason to go like very low carb or ketogenic.
Correct.
There's not a motivating health factor to do so.
Correct. In fact, my high intensity / CrossFit, unhealthy obsession kind of prevents me from wanting to do that as well.
But the new piece of data, not necessarily a new piece of data, but a new understanding that we've came upon is the total plaque score and what exactly it was. Last podcast, we sort of kind of dumpstered it. We weren't sure exactly what it was. And I still stand by that judgment. Because I did find out what it was. Actually, I had reached out to Dave Feldman on Twitter after our last podcast, and he said that the exact methods would be in like the methods and materials of the study when it's published. To his credit, he did respond, and he gets a lot of messages and comments, so I appreciate that.
We do.
And then I came across a paper that had used this several years back, and they sort of outlined this is what a total plaque score is. This is what a segment involvement score is, both of which are primary endpoints, and they were used in these baseline analysis of the patients.
I thought it would be a fun thought experiment. Let's take, for example, the total plaque score. Let's take the highest one in the group and try to figure out what the stenosis on that patient could have looked like.
Yeah, this is actually a common misconception in the critics of the study. The critics of the study are saying, well, they're studying people without heart disease, so of course they're going to get the result they want. There's actually about half of these patients who have diagnosed coronary artery disease. The highest total plaque score is a 13. So let's talk about what that means.
Yeah, so 13 could mean that there is 13 different segments with a 1% stenosis, 1% maximum stenosis, or a 2% stenosis. Or it could be that there are 13 areas with a 48% stenosis, a little bit different plaque burden there. It could also mean that there are 4 areas with a 80% or 71% or 95% stenosis. We'll post the how I'm getting these plaque scores here, and then 1 area with a 48% stenosis.
Yeah, all of those are possible. It's basically like you can add up a lot of different ways in multiples of 1, 2, or 3 to get to a total score of 13. So the maximum score, like we mentioned earlier, of a total plaque score is 45. You divide the coronaries into 15 segments. And for those listening, a score of 1 in a given segment is a 1 to 49% stenosis. A score of 2 in a given segment is a 50 to 69% stenosis. And a score of 3 for a given segment is a 70% or greater stenosis.
Mhm.
So a lot of variability there. So if you are just looking at a change in total plaque score, you could, in theory, the very first example you gave, someone has let's say 10% stenosis in every single segment, or all of them but 2, so they have a 13, just like this patient. And then they double that. Now they have 20% stenosis in all those same areas.
Yep.
Total plaque score is unchanged. Now, I don't think that's what they're reporting. I certainly hope not. It says plaque volume.
Yeah.
And volume is going to be a number. It's not going to be a sort of calibrated score like this.
Yeah. That's probably different. But it would have been nice to see a total atheroma volume. I believe it's measured in cubic millimeters. And they could have just posted the before and the after, again, on analyses like Cleerly. That is pretty apparent. And they actually could have posted the calcified and uncalcified and calculated low density plaque, which may or may not be unstable plaque. But it would have been nice to see the change in plaque density, because one of the known, I guess, benefits of statins is that they can change the characteristic of the plaque without changing the amount of plaque. So maybe that's true if you go on a reverse statin like testosterone. Maybe that's true if you go on a ketogenic diet. But we don't really know those things.
Yeah, it's a good point. And another primary outcome is the segment involvement score. This is just those same 15 segments and whether or not there's any plaque in any of those segments. So they actually didn't release this baseline data, so we don't know how many segments that person with a total plaque score of 13 had. And I'm interested to know, I know a lot of clinicians listen to this, if there's any cardiologists that are listening, is a total plaque score or a segment involvement score something that you are seeing in journals or on reports or cath reports or things like that you're doing? I'd be interested to know if this is translating to something used in the real world that I'm just not in tune with.
Yeah, it could be. And if there's any lipidologists or lipid experts that are listening, we'd love any insight. Again, we just want to figure it out. So we are not being a hater, and we'll give some actionable advice about what we will try to do. And we're more than happy to help. But whether you're somebody that thinks we are crazy for even considering looking at the response of plaque and plaque volume, or whether you're somebody that thinks, you should never use medications and higher cholesterol, the better. There's a lot to be gained from this. So I guess we should also talk a bit more. We did briefly touch on Cleerly earlier in total atheroma volume, but we really haven't talked about stratifying by, the actual percentage stenosis, stratifying by which artery it's in. For example, you brought up a good case of someone with plaque, but only in an RI, the ramus intermedius. So things like that, where there may be higher amounts of plaque, but it's hard to say how, it can certainly be more or less significant. So if you have let's say you have a 69% stenosis in your left main, that's a score of 3 in your plaque score. But what if that's in, the distal circumflex, and how would that vary as far as management?
Yeah, I mean, that puts you in I forget the exact CAD-RADS, but I think it's like a 3B. They have like 3A and 3B now, but It's a significantly more troubling CAD-RADS score than it is a total plaque score. And if you go a step further and you see this on a Cleerly, you're like, oh, wow, this is a problem. Because even your base CCTA is probably going to say, oh, it's a 50 to 70% stenosis. And this is probably something they would call back on. They would say, hey, this is a problem.
Speaking of CAD-RADS, is that best used for those with chest pain that could be anginal, or just individuals at risk of ASCVD that may or may not be having chest pain?
Yeah, it's standard reporting. They're trying to standardize the language, like a BI-RADS or a PI-RADS, any of these other sort of disease, in those cases, cancer screenings. In this case, screening for coronary artery disease. If someone is having anginal symptoms, usually they're going to go ahead and if they think, yeah, odds are it's more likely this is anginal versus musculoskeletal chest pain, they're going to go ahead and cath them because then you can do the intervention at the same time if there's something that needs to be done. For someone who is trying to gauge their risk and whether or not they should be placed on either an initial lipid-lowering therapy or intensification of lipid-lowering therapy, that's where the CAD-RADS scoring and CCTA analysis really plays the best role.
Yeah, that's a great summary. How about density of plaque? We talked about how density may or may not equal stability, but I guess, what do we know about validity so far? We'll post a link to a study that discusses it to some degree. And what can people take away from that?
Yeah, I mean, for me personally, I don't think unless, let's say I got a CCTA, which I plan to do someday, and I run it through Cleerly, because I don't trust the radiologist that says no significant stenoses. I said, my question was, are there any stenoses? Don't tell me what there's not. Tell me what there is. So I run it through Cleerly, and I see that I do have, or let's say I got a calcium score of 50. And I run it through Cleerly after my CCTA, and it's 100% calcified plaque. I probably am not going to intensify anything that I'm doing to lower lipids. Now, if I have, let's say it's a 50-50 split of, soft plaque versus calcified plaque, I'm probably going to intensify what I'm doing because that's a bit more evidence that something has been developing more recently.
So you're saying if you don't get a CCTA and your calcium score goes from 150 to 300, because you've been on your statin, the plaque has been calcified, that could actually be a good thing.
It could be a positive, yeah. Calcified arteries doesn't sound like a positive thing, but it depends on your relative starting point. Just like an A1C of 7 doesn't sound like a good thing. If your starting A1C was 12, an A1C of 7 means you're doing a great job getting that down. Of course, depending on the timeline.
Yeah, makes sense. Maybe think of calcified plaque like if you've had a cavity fixed. The calcium score is only going to detect the cavity where you have the metal or amalgam fillings, whereas the soft plaque, which tends to be more dangerous, those are cavities that have yet to be detected by your dentist, which is the calcium score in this,
And the dentist is the bad guy.
The dentist is, I guess, the CCTA and the calcium score. Or the dentist is the CCTA and the statin because he's calcifying those cavities.
The dentist is the interventional radiologist.
Yeah.
And the statin.
Anyway, that was an unplanned analogy. So maybe it hit home, maybe it didn't. Yeah, I guess any other takeaways from the Cleerly analysis that we haven't mentioned yet?
Yeah, I think just total plaque volume, would love to see the baseline characteristics there. Percent stenosis. Again, we mentioned that. That'd be great because you can measure very precise changes and see what kind of an effect you're actually having on blood flow. I guess you can't if it's indeterminate. A lot of times they'll say do a fractional flow reserve test. But for a CCTA, seeing a change in the percent stenosis tells you a lot about what's happening with the blood flow. So yeah, I think adding a Cleerly analysis would be a no-brainer if I was running this study. Maybe they'll go back and do that analysis at some point.
Is there a rough estimate of when you would want to Cleerly? Let's say you haven't had a cath, you've had a calcium score, and maybe it's 500, maybe it's 1500. When is it too high to get a CCTA with Cleerly analysis?
When is your calcium score too high?
Yeah.
The calcium score is never too high because your goal is to use the CCTA, use the Cleerly to stratify. Is this all, calcified plaque? Is this all not calcified plaque? If let's say I'm in an area where I'm not near a Cleerly and it's going to be, let's say 6 months and I've got a calcium score of 1300, I'm probably going to act like I have heart disease. I'm going to manage that person like they have heart disease until we rule in or rule out whether they do have a lot of soft plaque that's sitting there. Odds are it's going to be a mixed plaque. Most people, the average LDL is not all that high. The average LDL is 120, but the average person is still dying of a heart attack or a stroke.
Yeah. Another thing that I like to think about is, you want to have a long health span. And even if the plaque in the coronaries doesn't kill you, the plaque in your brain certainly can. It can lead to ischemic cognitive disorders. The plaque in the vasculature leading to your genitals can also decrease your quality of life quite a bit as well. Known association with high Lp(a). So there's a lot of reasons to do it. And some people say, well, I want to live like a king. and eat my steak and, drink beer, liquid calories and sugar and whatnot. And then when I die. But do you want to really risk of having a stroke, which basically cripples you? You're
not guaranteed a quick and easy exit from the world.
Yeah. The concern for morbidity is at least as much, if not more, than the concern for mortality. So hopefully that is a good summary. I think that's probably a good place to end it today.
Yeah, I think it's a good place to wrap it up. We just wanted to add a bit to that conversation. Seems to be getting more and more traction on different social media platforms. Yep. People talking about it, people criticizing it, not really understanding the study. I don't think they actually looked at the page on clinicaltrials.gov. They certainly didn't listen to our first podcast on this. Hopefully they listened to this one and kind of know where we stand, why we're interested, and hopefully what questions this answers.
Yeah, we'll continue to propose more and more things for the future, in addition to just the Cleerly analysis. For example, repeating the Oreo study with certain types of fiber or even allulose added in. Lots of different things that science can look at in the future, hopefully as objectively as possible. If you have any personal anecdotes or stories, again, any comments are appreciated. Let us know with any criticisms and share this video as much as you can. So as always, thank you for listening. Thank you for your time, and may God bless you with health and happiness.